Wow, with this silence, I feel like the priest before starting the Mass. Come on, this is not a church. It's good that you keep silent, but we want you to be alive and lively, okay? So welcome to this session. It's a Medtronic-sponsored session. It's dedicated to a topic that we really love a lot, those who are in the panel and myself, is drug-coating balloon and the possibility of a clean vessel. We have discussed about this title for weeks, and this was the simplest one we could have in mind. The idea is to show you on a cases based the possibility of treating even complex coronary artery disease without the absolute need of implanting permanent coronary stents. So this has to do with the long term, it has to do with the future of our interventions. Of course, we hope there will be a lot of debate for that. You know, the format of this session is declaring the objectives of the study, which is the reason you are here. And this is to know how to prepare the vessel, deliver the therapy, and evaluate the immediate result after a DCB-alone PCI. So whether you are comfortable with this result without the stent, and how can we, I wouldn't say convince, but discuss with you that this is an acceptable result. To discuss de novo, small vessels, and in-stent restenosis, so totally different scenarios, with follow-up and define what might be an optimal long-term result, which is, of course, what really matters the best in the patient. And to refresh some scientific basis and understand the clinical benefits and safety of the paclitaxel drug-coating balloon. So to do that, you know, the session will be based on, first, a presentation of the scientific basis that you may know, but maybe you don't remember. So this will be the basis of the following discussion on the cases. We will have 3 cases, and we have a moderator. The moderator is Professor Zaman, and he will explain you how it works with the communication among those who are in the room. This session has also the opportunity of getting questions from those who are not personally here, but are following the session by remote. So with no further delay, Azfar, please go ahead.
Thanks, Flavio. So those of you who are here in person, there are microphones dotted here at the front and at the back. Please I encourage all of you to ask questions of the speakers and of the panel at the end. Those of you who are listening and watching this remotely, we have a chat master who's Simon Eccleshall. During the course of the talks, please feel free to type in questions. We will collate all of those questions that are of a similar nature and make sure that we address them with the speakers. Thank you.
Good. If that it's all clear, we will start with Professor Bruno Scheller. You all know Bruno is a pioneer in the technique, and he has performed a top-level research in the field of drug-coating balloons.
Perfect. Thank you very much. Great pleasure for me being here. It's totally nice to meet people in person and not only by virtual meetings. So I think it's a very great day today. How did it start, the story of drug-coated balloons? It started with contrast media. We were looking more than 20 years ago for non-stent-based alternatives for local drug delivery, and we had the idea to use the contrast medium as a solvent for drugs, in this case paclitaxel, to deliver this drug to the vessel wall of the treated vessels. This worked very well in the animal model. We found a dose-dependent reduction of neointimal formation in the porcine stent model. However, it was difficult to clearly define how much drug you deliver to which part of the vasculature. And at this time, we knew from the other experimental data from the drug-eluting stents, they were underway, that long-term release is biologically efficacious. We had the information from the contrast media that a short time repeated injection of the drug leads to a biological effect. And so the idea was born to do something in between, to coat the balloon, because it's very lesion specific, but it does not require this stent platform for local drug delivery. And this was the first successful animal trial we did at this time. Again, the porcine coronary stent model with overstretch, and those stents were implanted either with uncoated balloons, with balloons coated with pure paclitaxel without additives. And furthermore, we had the formulation using the contrast media as additive, and for this formulation we found a highly dose-dependent reduction of neointimal formation after 4 weeks in this animal model. So this was the first proof of concept in a biological model. Later on, we learned that it's not only the excipient that plays a role in the efficacy of a drug-coated balloon, it is also the coating procedure. Here is very nice work from Juan Granada's group. They showed that there's a big difference between amorphous and crystalline coatings in terms of drug delivery and drug persistence in the vessel wall. Here you can see, again, in the porcine model at 4 weeks, compared to the initial formulation, the paclitaxel iobromide coating, the results of the paclitaxel urea coating. And here again, you can see a dose-dependent reduction of neointimal formation, and you see that the sweet spot for this technology is a paclitaxel concentration of about 3 microgram per square millimeter balloon surface, which is still the dose for the so-called high-dose DCB we have. And with this formulation, you can see we have very long persistence of the drug in the vessel wall. And after 6 months in this porcine model, we see still therapeutic tissue levels of paclitaxel. And we have differences between different types of DCB coating. Here you can see, again, a preclinical work, PK data, tissue concentrations of paclitaxel for 3 different FDA-approved peripheral DCB. And as you can see here with the impact, you have the longest persistence of the drug in the vessel wall, and this may explain why we see here the overall best clinical results. Another lesson we had to learn, again from the peripheral arteries, was that dissection is not the enemy of the intervention procedure. Dissection is the mechanism of angioplasty, and in the case of DCB, it improves drug transfer to the vessel wall. Furthermore, we learned that the preparation of the lesion is the most important step of your procedure. You can see an analysis of the treatment of in-stent restenosis from Antonio Colombo's group, looking for an acceptable result versus a not acceptable result. This means a diameter stenosis more than 30% or a relevant dissection in the treatment of in-stent restenosis. And here you can see that there's a big difference if you reach the goals of your lesion preparation or not. This is another study from Japan, looking more in detail on specific parameters of the quality of your lesion preparation. And once again, you can see that if you have fulfilled all these criteria in terms of diameter stenosis and other parts of your procedure, you have the best outcomes. If you do not fulfill this criteria, the outcomes are worse. And this leads us to the clinical application of DCB, the so-called DCB-only concept. The most important step of your procedure is lesion preparation. You have to do this as good as you can and as aggressive as you can. And after doing this, you have to decide if this result of my lesion preparation is acceptable or not. And the proposed criteria for acceptable are a diameter stenosis of less than 30%, non-flow limiting dissection. This means type A and B dissections are fine. We may talk during the sessions about type C dissections. And of course, you need a good flow. If you fulfill this criteria, the recommendation is not to implant a stent, use only the DCB for local drug delivery. If you have an suboptimal angiographic result, then a current generation drug-eluting stent should be implanted. And for me, the most fascinating aspect of this DCB-only therapy with paclitaxel is that we see an effect so-called late lumen enlargement. This means you have a shift from the left to the right after your procedure to follow up at several months in your MLD distribution. This means you can accept a not stent-like result at your index procedure, and you will end up with better lumen over time. And this is very unique. This is not the case with stent-based approaches. Here an example of such a case, treatment of the circumflex artery with an DCB only. This is the initial result. This is 5 months later. The area treated with the DCB has the best lumen in the circumflex artery. Another example from the PEPGAR-BIF trial, a bifurcation in the circumflex artery treated with 2 DCB in both directions. This is the initial result, haziness, not stent-like. And if you look half a year later, the dissection has healed and the lumen has improved. And that's what we typically see after a DCB-only treatment. And this late lumen enlargement is explained by a growth of the total vessel area, very similar to the Klagow effect in the early phase of atherosclerosis. And furthermore, we have some data showing that in some cases, after paclitaxel-coated balloon angioplasty, there is a decrease in total plaque area, which is very fascinating. What about other drugs than paclitaxel? We have very few data so far for a limus-based DCB. We could publish recently a novo trial conducted in Malaysia, comparing the sequent Bleeds with the sequent SCB balloon. And as you can see, both have very good results in the novo disease. However, this effect of lumen enlargement is mainly a paclitaxel effect, and this has not been seen in the majority of cases with sirolimus. So my conclusion is that paclitaxel-coated balloons are still the standard of care for DCB treatment. You should follow the rules of DCB only. This means lesion preparation is the most important step of your procedure. And then you have to decide, does this lesion require stenting, or is it possible to treat it without stent implantation? And late lumen enlargement, in case of paclitaxel-coated balloons, is the key for the treatment of the novo disease. Thank you.
Okay, now we have the information we need to start watching at our cases, because Bruno has shared with us the basis of the mechanism of action. And the first case we have prepared is respecting the guidelines. I mean, treatment of in-stent restenosis by DCB is considered by the European guidelines as a class 1 indication. And so we will start with the case. Look at this young guy, born 64. In 21st January of 11 years ago, he came to our observation because of stable angina, and he had a known bicuspid aorta. You see there is a lesion on the proximal part of the LAD and a lesion on one marginal branch. So it's stable angina, 2 vessels. The bicuspid at that time was non-severe. So at that time, he got 2 bare metal stents. Okay, I don't know if that was a good idea, because at that time we had really new generation drug-eluting stents, but the results are angiographically accepted. It's a bare metal stent 3.518 in the proximal LAD, and it's a 2.5 short, 12 millimeters on the oblique marginal. He did well, but just 6 months later, as we know it happens, it had recurrence of angina. And this is what we expected. The small stent is almost totally occluded, and there is a focal restenosis on the proximal LAD. So second attempt, different operator. It was very unfashioned to trust on what at that time was the standard of care stent, a everolimus-eluting stent, the science prime, went 2.523 into the oblique marginal, and another everolimus-eluting stent, 3.523, went inside the previous bare metal stent. So you might think that this is also recommended in the guidelines. This is okay. This is what should be done. The final result, it's angiographically guided, so there is a little bit of a mishap there. I mean, it should be better to analyze these stent failures with intravascular imaging. But anyway, the angiographic image was, I'd say, acceptable. This is the LAD and the oblique marginal. But exactly 6 months later, the young guy came back with the same symptom, complaining from stable angina. The right coronary artery remains unchanged in this year and a half. And what we see, it's again a subocclusion of the science on the small marginal, and again, a focal restenosis on the proximal LAD. This time, the operator was a different one. This is the case I did this time. And as I said in the beginning, I am a strong believer in drug-coating balloons, and at that time, that was already mentioned in the guidelines. And this is a little bit of old-fashioned drug-eluting balloon, is the Falcon prototype. It was not an easy stent to push, but it went 2.513, a long one into the oblique marginal. You see the immediate result, which is totally acceptable. And then it's a 2.320 drug-eluting balloon, paclitaxel in the proximal LAD. So what happened 6 months later? Nothing. The patient did very well for 9 years after this procedure. We actually, I wouldn't say we lost him for follow-up because it's not true. He was followed up because of the aortic stenosis. And 9 years later, he had this echocardiogram. You see the mean gradient is 46, so the aortic stenosis became severe, and he became mildly symptomatic for shortness of breath. So the indication at that time, this was last year, in July 21, 1 year ago, of course, was surgical replacement of the bicuspid valve at the age of 60 or something like this. But the surgeon said, this is a long-lasting history of coronary artery disease. We want to know whether we need to implant a mammary on the LAD. And so he accepted to undergo this angiogram, which was, of course, I was very interested on knowing, you see the right didn't change, but not even the left. This is 9 years follow-up of these two, I would say, aggressive and recurrent in-stent restenosis of bare metal stent and recurrent in-stent restenosis after science. And this is another view of the LAD. And at that time, I decided to do an IVUS because I was curious to see which could have been the mechanism of this restenosis. And look, which is interesting, is how clean is the small stent of the marginal branch. There is absolutely no neointimal growth inside this small stent. And when you have a look at the LAD, what you will see, the double layers of stents, and at a certain point the stent is underexpanded, exactly here in this moment, because there is a calcified vessel with 360 degrees. So probably if we go back on time, we would have used different devices to optimize the results of this poor science stent that was guilty to be recurrence after only 6 months. But what we know for sure is that he did very well for 9 years after this aggressive restenosis treatment with drug-coating balloon. That's the case, and I would suggest Azfar that we start some discussion at this point.
Yeah, great. Thanks, Flavio. So the chatmaster questions have really gone crazy, which is fantastic. So before we go to the chatmaster, I'm just going to ask you, Flavio, that you did the imaging when the patient came back 9 years later. Now, the guidelines now recommend that if you see a case of ISR, that imaging is mandatory. Would you agree with that, so that it now guides how you deal with the ISR depending on what you see on imaging?
Absolutely. Doing the eye was the first time it would have shown that the stent on the marginal was undersized. Yeah. And that the stent on the LAD was not well expanded because of this calcification. Yeah. So that was the first mistake. Second one, when we implanted a second drug-eluting stent, same thing. But what I want to underline, I myself didn't do the IVUS at the third treatment. I just relied on the drug-coating balloon. And it is so effective that despite the fact that the stents were undersized and the LAD stent was underexpanded, it caused a total, I'd say, killing of the neointimal hyperplasia. The stent remained patent despite the, I'd say, suboptimal angiographic result.
Yeah. So the role of DCB in ISR is that it's a type class 1A recommendation, but do image to find the cause of the ISR, whether it's mechanical, stent fracture, stent under expansion, or whether it's neointima, neoatherosclerosis. That will determine how you deal with it next. If we go to the chat master to address some of the questions out there in the ether. So Bruno, there's a question from one of our observers asking, if paclitaxel has been the word they use as discredited in the drug-eluting stents, how is it still being used for drug-coated balloons, and should we be still using it?
So number one, I would be careful that it was the only fault of paclitaxel. When we look at the two first-generation drug-coated stents, I think there were many other technical and engineering aspects playing a role in this decision. With respect to DCB, paclitaxel is the perfect drug for this because it has irreversible binding to the cells. And we have only this short delivery time of 30 to 60 seconds. So it's very important that there is a perfect persistence of the drug to have a long-term biological effect.
Yes. So it's still very effective in drug-coated balloons, but not in drug-eluting stents. Yeah, great. There's quite a few questions about dual antiplatelet therapy duration. Okay, so people have asked, in patients at high bleeding risk, is the use of DCB an option, and can we restrict it to 4 weeks?
So I can tell you that the recommendation of the DCB consensus group is only 4 weeks after DCB treatment. Except you are in a situation of acute coronary syndrome, of course, then it's longer, or if you implant additional stents, then the stent is gives the time. However, we have to should be aware that this is an expert opinion. There are many reports and experiences in patients at very high bleeding risk that have to undergo surgery near term. Only aspirin is also sufficient in such very high risk patients.
Yeah, I think this is an area that will need further exploration, and I do believe that we can reduce the duration. One last question before we move on. So there's questions about, Flavio, about whether we can use DCB as in a hybrid role. So for the example that the person has asked is, can we put a stent in the left anterior descending artery and treat one of the branches with a DCB?
Okay. Before answering, I want to remind you that it's very good that we are together in this room, despite the fact that we will back home with COVID, we don't know. But there are microphones. So if you want to make questions, do it. I mean, the microphones are there for you. The hybrid treatment, I think that we shouldn't consider DCB as an antagonist to stents. It's a complementary therapy. So if you have a short lesion, very calcified, and you want to put a stent in the proximal large vessel, that's fine. If you have to treat all the diffuse disease on the distal LAD, it's not good that you put stents. So you can decide, this is a hybrid, what you mean. Then if you want to do it, everything with drug-eluting balloons, and you get even a good angiographic result at the end of the procedure, and you decide to spare the stent, this is also okay. But I think that we are not saying here you should not implant stents any longer. You should think twice, because the longer the stent, the worse the result. The smaller the stent, the worse the result. And we have an alternative, which is DCB. Yeah.
So one last question, sorry, because there's so many of these questions. Calcium. Okay, calcium and dissection are the two questions that have come up. Now, I'm going to ask you, Flavio, about calcium and Bruno about dissection. So at which point, and the degree of calcium, the arc of calcium, the length of calcium, do you decide that DCB is not an option?
Well, it depends on the angiographic results after you have pre-treated the lesions appropriately. I mean, lesion preparation is key. If you don't get a good angiographic result, even better if you do it intravascular, but let's stay on the percentage of residual stenosis. If you have 15% residual stenosis, this is not a good result. If you have recoil, you need to implant a stent. But if you get a good expansion of your balloon, the residual stenosis is 10%. I will leave the issue of the dissection to Bruno. The flow is good, the patient is doing well, the ECG is normal. I mean, you can leave it as it is, because the anti-proliferative effect of paclitaxel, it's amazing.
Yeah. So if I summarize, then what you're saying, if you see calcium, prepare as you would normally, get optimal preparation.
Yeah.
Then, if the dissection is not flow limiting, you
can
deliver the drug and leave it.
Yeah.
Okay.
Or at least you put a short stent instead of a very long one.
Yeah. Okay. Bruno, dissection. So one of the things that we need to, a lot of questions is, which dissections can we leave? Which ones should we stent?
Again, dissections are the mechanism of angioplasty. we know from all the trials from the past and the newer trials that type A and B dissections have an extremely low risk of acute and subacute vessel closure. You can leave it. Type C dissections are a little bit more complex because they are not always the same. You can leave some type C dissections. I would recommend to use additional measurements, hemodynamic measurements, FFR, whatever, and then decide if you leave it or not.
Okay, great. Flavio.
Well, next case is dedicated to small vessels. It will be presented by remote, but our colleague from Singapore, Frankie Tang, is he there? Can you hear us?
Yes, I can hear you. So can you hear me?
Fantastic technology, great image
Correct.
and perfect sound.
Yes.
So Frankie, share your screen and your case. You are very welcome. The room is full and we all look forward to hearing from you.
Okay, thank you very much. So thanks for letting me to join you online. I hope I can join you next year in Paris, in next year EuroPCR. So today I would like to share a case of de novo small vessel disease. So this is my disclosures. So we all love DCB. We know that DCB is particularly useful in ISR and also small vessels. So today my case is concerned about the use of DCB in de novo small vessel disease. So we know that small vessel is attractive to use DCB because we don't want to put in long stents in long diffuse disease and tortuous vessel. We try to avoid metal caging. Sometimes in PCI, there's a lot of negative remodeling. We hope that after the DCB, the vessel may grow inside as spoken by previous speakers. And also in young patients, we try to preserve targets for CABG if there's recurrent disease. So let me show you a case, an interesting case that actually illustrates a lot of things that you guys have discussed in the last case. So this is a 73 years old man. He has hypertension, diabetes. He presented with CCS class 2 stable angina. The examination is essentially normal, but the CT angiogram showed severe stenosis in multiple sites such as the proximal LAD, the circumflex, and the ramus intermediate. So this is the angiogram. You can see multiple site stenosis in the circumflex, ramus, and also the LAD. But you can see the LAD is quite long, diffuse, and also calcified with some disease in the diagonal. So take a look at the still images. So get lots of tight stenosis in various sites in the coronary artery. So we can debate a lot what is the strategies here. So some people may try to use these DCB, some people may put in long stents from here or here, then here, and some people will just treat the LAD or leave this for medical treatment. So what is our approach here? So we just, as I agree that lesion preparation is the key. So we do some pre-dilatation to the circumflex lesion. And this is the result after the POBA. So we can see not much dissection, stenosis is less than 30%, very good flow. So in this case, we put 2 DCB instead of putting long stents in the circumflex. So this is just to illustrate how well the prevail DCB delivered down to the circumflex. So we put 2 DCB, 2.0 by 20 and 2.5 by 15. So this is the result after the DCB. It's quite okay. Then we turn to the ramus. So we try to prepare lesion by using non-compliant balloon, a prolonged inflation. This is the POBA. And this is the result after POBA. Again, you can see the result is quite okay. Minimal residual lesion and also no flow limiting dissection. So again, we adopt a DC approach here. We delivered a prevail 2.5 by 30 DCB to the ramus intermediate, and then this is the result after the DCB. So very nice result, and you can see this is a lot of angulation and tortuosity, such that I really don't want to put a metal cage here, a small size metal cage here. But how about the LAD? So this is a big size LAD, long, diffuse, and calcified disease. So this is the OCT. So you can see we already appreciate some calcium even on the fluoroscopy. But on the OCT, we can see clearly there are thick concentric calcification along the whole LAD from proximal to the mid segment. You can see here, here, and here. So I think most of you agree with me that for all this calcium, we really need a very good lesion preparation. So I first used the orbital atherectomy to try to do some debulking from proximal to mid LAD. We can see these are the effect of the debulking. We can see this debulking here, which reduce the calcium volume. And afterwards, I adopt shockwave lithotripsy to create some cracks on this concentric thick calcium. So after debulking and calcium and IV lithotripsy, in this case, because of the proximal big LED, I adopt a hybrid approach, putting 2 drug-eluting stents. So Restenosis Onyx 3.026 and 3.018. And on the diagonal, I adopt a DCB approach again. So we DCB the diagonal and we do kissing balloon inflation. So this is the angiographic results. So the LED looks very good. And the OCT, you can see the stent expansion is quite satisfactory, very round. And on the longitudinal view, you can see the stent expansion is also quite good. So ladies and gentlemen, in conclusion, I think coronary DCB expand our armamentarium for complex CAD. And DCB is particularly useful for ISR and also de novo small vessel disease. And I agree with the speakers previously mentioned hybrid use of intracoronary imaging, atherectomy devices, drug-eluting stent, and DCB. They are not antagonists, okay? They are complementary. So usage of all these are essential for performance for complex PCI for our patients. So thank you very much.
Thank you, Frankie. Thanks, Frankie. I'm going to hold you there for some questions. But before I come back to you, I'm going to ask the audience, because one thing we didn't do is define what we mean by small vessel. So I'm going to ask the audience to put hands up here. Those of you who think that a small vessel is 2.5 millimeters or less. Okay. Those who think it's 2.75 millimeters or less. Those who think it's 3 millimeters or less. Okay, so Frankie, the overwhelming majority believe that a small vessel is 2.5 millimeters or less. So when you gave that presentation, fantastic results. In your practice, what size of vessels are you dealing with when you use DCB?
So in my case for de novo small vessel, so I agree with most of the audience, so 2.5 or less. So I think nowadays I rarely use the 2.0 or 2.25 cents because of a DCB.
Yeah. And what proportion of your cases are you now treating with DCB alone?
So if talk about 2.0 or 2.25 vessel, probably more than 70% I will just adopt a DCB only strategy.
Yeah, and your overall practice of all the PCIs you do?
Probably maybe 20%.
20%.
20%.
Okay, I'm going to ask the audience again. So those of you who do not use DCB at all, so 0%.
They're in the other meeting.
Okay, yeah, they're in the other meeting. That's good. Okay, those of you who are around 5% or less. Yeah, okay, 10%. Okay, greater than 10%. Okay, so the mode is around the 10% mark, and I think that's about right, certainly for the UK. If you look at the registry, it's between 5 and 10%. So I guess, Frankie, from what you're saying in your practice, and I liked your use of the word complementary. So we're not saying that this is either or. It's not drug-eluting stents or drug-coated balloon, but the drug-coating balloon is complementary for an interventionist and may help you to either reduce the number of stents or reduce the length of the drug-eluting stent that you use. Yeah? Asif,
Yes.
Great. We've got post-COVID generation talk.
Thank you. Thank you, Frankie, for the talk. So my question is, when we talk about some ostial small vessel, or like, for example, diagonal with LED, we always say whenever you have ostial lesion, there's always extension of plaque in the main vessel. So we're going to treat, for example, if sometimes we see isolated diagonal lesions and we sometimes get away with just on medical management, or either we just put a DCB in there and there might be a 30-40% plaque, which may be only visible on imaging guided, not angiographic guided. So should we land our DCB in a few stent, we can say dots back in LED and just say, we treated the ostial diagonal and leave the LED, which have a 30-40% plaque, which may cause some disruption to LED plaque. We don't know.
Yeah, yes, that's a great question. So if you really have an isolated diagonal disease with minimal plaque and LED, I would think DCB is actually is my preferred strategy in those cases. So it's okay. You just you use the non-compliant balloon to prepare the ostial lesion. If there's no full limit dissection, and then just DCB there, and afterwards you know what happened to the ostial diagonal and also the main branch. So if there's no obvious dissection in the main branch, I think we can just leave it. Of course, sometimes we can do intracoronary imaging, for example, IFS or OCT. You will be even more confident, okay, to leave the main vessel alone. But I think DCB is a very good approach for isolated ostial lesion.
Yeah, feel free, please come on.
I'd like to ask about in the small size vessel, 2.5 or less, long-term results of DCB versus small-sized stent. If any data, I always use this tracheotomy balloon in in-stent restenosis. Yes. And also, is it effective? And regarding data regarding in the in-stent restenosis.
Yeah, Bruno.
In comparison to plain balloon.
Yeah, of course. So data in small vessel DES with DCB. I'll let you answer that. Yeah.
Then we have to define again what small vessel is. If you say okay, it's fine 275 or smaller, then we have the data from the Basket Small 2 trial. 758 patients randomized to DCB only or tracheotomy stent, and here we see up to 3 years almost the same outcome in clinical events. We have further data from smaller trials also going in this direction. The point is we do not see a clear benefit at this time because most of the patients undergo additional treatments with stenting. So there's no clear evidence that DCB has the advantage of no implant because those patients undergo frequently other interventions. So that's a little bit difficult to show a difference. No, this was small vessel disease. In-stent restenosis, overall, the hard clinical endpoints, death myocardial infarction, tend to be lower with DCB after 3 years and beyond. Yes. However, depending on quality of lesion preparation, you may end up in a higher TLR rate with DCB compared to stent. That's the data.
Okay. Yeah, at the back.
So in large stents, in-stent restenosis, where the original stent was no problem, there was no fracture, it was not underexpanded, it was well expanded, well chosen, and there is a new severe neoatherosclerosis, neoantima. Do you still choose DCB or a new stent, and why?
Flavio?
Well, you gave the answer. Neoatherosclerosis. Neoatherosclerosis is induced by the foreign body reaction created by the metal. So if you induce it once, it's not a good idea to do it again. So, on my opinion, when you have neointima, which is a reaction, it's an inflammatory reaction to the stent, and you have neoatherosclerosis, which is a process that takes longer. It takes more than a year and a half. And you can see that with IVUS or with OCT. I think that the best form of treatment is avoiding more metal. When what you see is stent fracture or evident stent under expansion, because the first one didn't have the strength enough to open the vessel, then there is a room for aggressive dilatation and eventually another stent to increase the radial force.
So there are two different cases. There are some expert consensus on that. So I'm talking the two different options. One is neoatherosclerosis, which may not be due to the stent, but it's just again is return of original disease, and the other is the neointima, the kind of neofibrosis, which may have been what you said, the kind of like keloid type of reaction. So because there are, and I'm not sure whether there's any data, some of these expert opinions saying if it's neoatherosclerosis, we should stent it. If it's rather the kind of keloid fibrotic tissue, we should cut it und DCB treated.
Well, the term neoatherosclerosis is not related to the natural history of atherosclerosis. Neoatherosclerosis is induced by the percutaneous coronary interventions, either by balloon or the stents, and it's much more frequent with stents. It's more frequent with drug-eluting stents, first generation, than with bare metal, and it's less frequent with new generations because it has to do a lot with the type of polymer we used. The other thing is the progression of atherosclerosis. This is not neoatherosclerosis. This is progression. And in all these cases, especially if you have neoatherosclerosis, the elution of the drug is very effective. And we will show some cases also on native vessels. There is all the rationale to treat atherosclerosis and progression with the drug delivery without the scaffolding of the metal. While for the neointima, this is the class 1 indication because it's the neointima, it's a very undifferentiated smooth muscle cell. So they are very sensitive to the paclitaxel or even the sirolimus, but more by the paclitaxel, which is cytotoxic.
Okay, thank you.
That's great. So I'm just going to summarize then from the second case is that for ISR, imaging is important. Define the mechanism and then treat accordingly. There's other questions, lots of questions on the chat master, so thank you. Frankie, you touched on this thing, but one of the questions is we're able to use lesion modifying strategies such as rotablation and that to lesion prepare beforehand, no concerns.
Yeah, no concern. But of course, if you create a lot of the sections, flow limiting one, then probably maybe putting a DES.
Yeah.
So we can always assess after the
correct. Yeah. So
preparation.
Prepare well, and if the dissection is not flow limiting, go ahead and deliver the drug.
Yep.
Yeah. One last question before we move on. We're running out of time. Actually, we're behind schedule. Any concerns about creating an aneurysm following a dissection with a DCB and the effects of the drug? That's one of the questions. Have you seen a case of aneurysm creation?
Not exactly. I see cases of aneurysm, but not due to DCB.
No.
It's due to first stent or concealed perforation, but not the DCB.
I've not anybody. Bruno?
The only exception is if you do CTOs and subintimal recanalization, then you may have a higher risk for aneurysm, but that's the only situation.
That may be what the question is.
But then you will have aneurysms also after stenting.
Yeah. One last question, then we have to...
One last question it's a technical question. As soon as the drug-coated balloon is in contact with the blood, it starts losing the drug. Is this true? Do we have to deliver quickly the drug-coated balloon to the
Bruno,
place?
this is yours.
Yeah, it's true. All DCB lose drug on the way to the lesion. Therefore, we say it should be administered within 2 minutes. First time contact to the blood, and then inflation at the lesion. If not, if you do not reach this goal, then you have a plain balloon over time, and then the efficacy is worse.
Optimal duration of the inflation?
At least 30 seconds. That's what we know from the animal models. If you can do 45 or 60 seconds, it's fine.
Great, thank
Bruno,
you.
is that 2 minutes for all the different balloons out there?
2 minutes, I do not recommend 2 minutes because the patient does frequently not tolerate
Sorry,
it.
2 minutes to deliver.
2 minutes to deliver is
All balloons. All
the balloons I'm aware of, yes.
Okay, yeah. Okay, great, thank you. So we've had ISR, we've had small vessels. Flavio, if you could tell us about de novo lesions, please.
Okay, thank you, Frankie. Thank you very much for this nice case. It's a pity you are not here, but thank you for this timely presentation. Well, this is a presentation that I want to tell you. It's about, not it's in-stent restenosis, it's de novo lesions. It's a young patient. Again, I think talking about young patients is very important because life expectancy, without being too unlucky, is very different to that of old people. So we have to think about long term. This is very important. 48 years old, negative previous cardiovascular history, normal left ventricular function, admitted with chest pain at rest. Look at this disease. It starts at the level of the first septal, at least it seems. If you do OCT, it starts at the left main probably, and it goes up to the distal part of this very big LAD that it's going around the apex and providing practically the posterior descendant. What to do with this? Is it a case for full metal jacket? Is it a case for mammary artery? Definitely yes. Mammary artery is the best thing you can do. The patient will never die from infarction or heart failure. But at the age of 40, it's difficult to digest. I just remember you that full metal jacket was born to kill. And And dying young, it's a very bad thing. I think dying old is also unpleasant, but dying young, it's unacceptable. So I wouldn't recommend you to metallize all this vessel from tip to toe. So what we did was balloon dilatation, 330 from the distal part to the proximal part, and this is what you get. This is balloon lesion preparation. And then this is the implantation of a bioabsorbable scaffold in the proximal part, and all the rest is drug coating balloon. Okay? Yeah, I wanted to show the face of Phil Collins because he has this nice long play. It used to be called long play because it were CDs, not jacket required. Because this image you will take home. You will take home the image and the music. But what is more important is that you get this image. I know it looks awful. You don't need to tell me. I am aware about it. And if you want to be convinced that it looks awful, do intravascular imaging, something that I strongly disadvise to do when you see dissections already on the angiography. Because if you want to see how it looks, you will see that it's really terrible. This is the OCT. And this is how it looks. Okay? This is how it looks. Okay. And this is the distal part of the LAD. But now I can show you also the proximal part of the LAD, which is nothing better. Okay? This is how it looks. And then you go to the BVS. These are the scaffolds, which are very well opposed. So you said, how would you decide to take the wire out? I mean, my decision is based on the flow, on the clinics, on the residual stenosis, and on the idea that I don't want to put these stents from tip to toe. And as I said, this long stenting of the LAD is not a good thing. And as Bruno said, the incidence of acute events after drug-eluting balloons is much lower than after stenting. So acute stenting is thrombosis is more frequent than acute abrupt closure after balloon. So this is the image we left. But what I want to show you is the result after a year and a half. After a year and a half, there is no trace of the dissections. There is no restenosis. The patient was totally asymptomatic, so he consent to undergo this elective study because he entered a prospective study because of the BVS. And as you can see, when you run the OCT, there are no more traces of the dissection. So dissections is healed immediately afterward. I mean, immediately. It's a year and a half, probably before. But we wait to see if there was a restenosis. And I can tell you more. I can show you the 4 years elective follow-up. So you'd say, why do you do that in Verona? I mean, are you controlling patients every 4 years? No, it's because of a protocol of the absorbed implantation in the proximal part of the vessel. And what you see is that after 4 years, there is some progression of the disease on the circ, on the distal LAD, but there is actually a vessel enlargement in all the segment that has been treated with both the BVS and the DCB. And this the distal OCT run, you see there is no image related to anything which could be Neoatherosclerosis. I go a little bit faster. Look at the side branches. Side branches are completely free. There are no stents. Okay? And I will go quicker and show you the proximal part where the BVS has been implanted. I have always been keen on the technology of leaving nothing behind. So I liked the BVS, although you have to wait 4 years to see a good result. Functionally, you see the physiology of the vessel is preserved. And this shows you the comparison. The awful image we obtained with OCT at baseline, the good image at 18 months, and which is amazing is the positive enlargement after 4 years. Look at the same sessions seen 4 years later. All the vessel got bigger at the place where the BVS was implanted in the proximal part, but especially at the distal part. Look, these are the dissections, and this is the lumen after the immediate result. This is 18 months, and when you check it at 4 years, the vessel actually is bigger than it was when we did the treatment. So this is case one. And case 2 is very similar. It's again very young, 41 years old male, just with some dyslipidemia, but nothing else, coming for the first time in January 2014 for chest pain, but chest pain that we did not understand. No troponin, no ACG, no echo abnormalities, but this LAD. Okay, the right coronary is normal. And this is the LAD. You may argue, well, this is spasm, this is an arteritis. It's very unusual to see this kind of vessel when the right and the left, I don't say they are nice, but they are not so diffusely infiltrated. So that goes back on time to 2014. So the idea was either surgery with a very bad target because the LAD is really awful, full metal jacket, I told you already what I think about that, plastic jacket, putting a lot of absorb on it, or doing something like we did before. But first of all, we want to make sure that this is atherosclerosis, so you have imaging, and you see it's not spasm. There is a lot of plaque from the left main to the distal part. There is a lot of plaque. The plaque burden is huge, and this is how the vessel looks after a 2.0 balloon, and this is after a no jacket required reconstruction. Again, with one BVS, and with DCB 3.520 in the proximal part, a long DCB in the mid part, and another DCB in the distal part. And this is how it looks. Okay? This is the IVUS to check that there are no, in this case, no major dissections. There is good expansion of the BVS, and this is a 4 years follow-up. Imagine what would have been putting 10 or 15 centimeters of stent in this young patient. He's doing great. This is the OCT at 4 years, which shows a completely reconstructed artery wall. We can say that it is vasoreactive, it vasodilates, it's vasoconstrained, all the diagonal branches are free. And this is the no jacket required image that I want. It's the same color of the OCT. I mean, it's another detail that you will remember. And so this is a different medical practice, which is transforming a diffusely infiltrated atherosclerotic conduit into a well-functioning arterial vessel, not into a diffusely infiltrated metallic conduit. With normal arterial wall, without metallic tracts, with normal vasoreactivity, with free bifurcations, without stimulus for late neoatherosclerosis, and this is the most important thing we have to think about, with room for yet unknown forms of therapy. Whatever it will happen to this guy in 10 years, we don't know which will be the treatment. What we know is we have put 15 centimeters of stent, the alternative for future treatment would be much impaired. That's it. Thank you.
Thank you. Thank you, Flavio. So one of the questions that we need to ask is about the use of imaging. So I know we've discussed in ISR that it's mandatory to find the mechanism. What about if your a priori strategy is to go DCB? Is imaging mandatory? Because what you showed was fantastic images, but those images would put many people off a DCB strategy and would go straight for a stent. But because of your experience, you stuck to your strategy. So what's the role of imaging when you have a DCB strategy?
I think it's fundamental in lesion preparation to be sure that you have done a good job. But it's very, I'd say, it gives you a negative impression when you have to decide whether to leave it as it is or remove the wire. Because of the sensitivity of these images, I mean, the dissections look awful, and I wanted to show you on purpose. But I think you have to trust what is the basics of interventions. Good flow, no pain, no ACG. You wait for 10 minutes, and everything is okay. If you wait for 10 minutes and the vessel is occluded, you have the answer.
Yeah.
If the vessel is okay and you retrieve the wire and you wait for another 5 minutes, it's true. When you are at home and the telephone rings, the first thought is, I have to go to the hospital because of that. But when you have done many times and you see that it doesn't happen, and sometimes you go back to the hospital because a stent occluded of acute thrombosis, then it's a matter of numbers. And we need more numbers to rely on this decision, which is not an easy one for us. but it may be the best one for the patient.
Yes, and you've answered a question from the chats as well. So how long would you wait? And I think we've got the answer. It's around 10 minutes if you're concerned about the dissection. But typically, if it's a flow-limiting dissection, then you would go on to stent. Imaging, Bruno, you've done lots of DCBs. So your a priori strategy is DCB. What's the role of imaging in a de novo vessel?
I fully agree. ISR imaging is very helpful, but don't do it if you treat de novo lesions.
Okay, and I think that's the message. So I'm just going to wrap up now what we've learned today. So from this last case for de novo lesions, the key theme that runs through a DCB strategy is lesion preparation. Okay, DCBs are there for delivery of the drug at the lesion site. You must prepare the lesion adequately and leave a residual angiographic stenosis of 30% or less, and only then do you go on and deliver the drug. So that's a common theme. For ISR, imaging is very, very useful. I would say it's mandatory. You learn the mechanism and then act appropriately and accordingly. For small vessel disease that we saw from Singapore, Frankie's lecture, it's very clear that in small vessels, the risk of restenosis with metal stents is high, and the evidence, the largest amount of evidence that exists for DCB is in ISR and in small vessels. So that is an area where one would think that you can go on and increase your use of DCBs. Flavio, I'm going to leave you to wrap up now.
Well, I would rather prefer to leave these last 3 or 4 minutes for our colleagues if they have a question, because we have said all what we had in our minds. And perhaps
so one of the questions then is, and it was just after you showed your dissection. So in cases of SCAD, should we use DCB instead of stents? Bruno,
case
SCAD, spontaneous coronary artery dissection.
Wow, explain that.
Yeah.
Spontaneous dissection. Okay. No,
I would have said no, because the mechanism is very different to neoatherosclerosis. So I think when they saw your OCT of your last case, that's what must have raised the question.
Yeah.
Yeah, please.
Thank you very much. Dissection is a major concern about during use of DCB. Any tips and tricks to decrease the dissection? Type of balloon, size of balloon during preparation?
No. If we had that answer, stents wouldn't exist. The real reason why stents existed is because we were afraid of the acute occlusion and the restenosis.
So
but it's difficult.
What I would say to you is that what Flavio's case, the other thing that it shows, and I should have mentioned this in my summary, is the effect of flow-mediated dilatation. Okay? So because we all use stents, we think that you should have a stent-like result, i.e. 0 residual stenosis. Actually, what Flavio's cases have shown is that if you have a residual stenosis of 30% or less, you see what happens after 6 months, 1 year, or 4 years in this case. There is flow-mediated dilation of the vessel. So as long as there is flow, distal flow, it's not flow-limiting, you've seen that it grows. So you have to get out of this mindset that you have to have a 0% stenosis post DCB. Asi.
Just a couple of questions. So use of anything like integralin or something in non-flow limiting dissection, we can just leave it safely without use? Is that yes?
Yeah, I think that's a yes.
I mean, once again, the algorithm is prepare the lesion. Then you identify those lesions that end up in flow-limiting dissections. That's the reason why you should do lesion preparation aggressive. And then, for the rest, with the non-flow-limiting dissection, we have dual antiplatelet therapy, which was the key for the safety of stents, by the way, in the 90s, when the regime changed to dual antiplatelet therapy. And that's, you select the lesions by preparation, and you have, in addition, dual antiplatelet therapy for more safety.
And then the second note, in terms of recoil, we talk about sometimes we open the CTO and feel the vessel size is still very small after CTO. Can we DCB it and leave it and bring back? Is it a risk of that vessel closure is high, or we think that after CTO opening, we can just leave on DCB?
If you do long CTOs, you will end up with several parts of the lesion that require stenting. But the strategy can be to do spot stenting, in doubt the bigger size, and do the rest with DCB. So that's my strategy. And yeah.
Thank you.
Okay, and with this, we are perfectly on time to thank you for staying here, and we hope this has been useful. Thank you for my colleagues and Medtronic for sponsoring this session, and we wish you a very nice evening in Paris.